Hello everyone, and welcome back to another chapter of Advanced Pharmacology. Today, under Unit 13 of the Anti-Inflammatory, Anti-Allergic, and Immunologic Drugs, we'll talk about Chapter 55, the Cyclooxygenase inhibitors, non-steroidal anti-inflammatory drugs, as well as Tylenol. So, the family of cyclooxygenase inhibitors mainly consists of aspirin and their related drugs. Most of these agents have three useful effects. They can suppress inflammation, relieve pain, and reduce fevers. In addition, aspirin and only aspirin can protect against myocardial infarction and stroke. All of these effects are produced through one central mechanism, the inhibition of cyclooxygenase, the enzyme that's responsible for the synthesis of prostanoids, the same mechanism that underlies the principal adverse effects of gastric ulceration, bleeding, and renal impairment. Cyclooxygenase inhibition also underlies myocardial infarcts and strokes, which can occur with most of these drugs, but not with aspirin. So, its mechanism of action. All of the drugs discussed here work by inhibiting cyclooxygenase, or COX, the enzyme that converts arachidonic acid into prostanoids, or prostaglandins, and their related compounds. So prostacyclin, thromboxane A2. So to understand the drugs that inhibit COX, we must first understand what COX is itself. Cyclooxygenase is found in all tissues and it helps regulate multiple processes. At sites of tissue injury, COX catalyzes the synthesis of prostaglandin E's, or E2s, and prostaglandin I2s, which help promote inflammation and sensitize receptors to painful stimuli. In the stomach, however, COX promotes the synthesis of PGE2 and PGI2, which help protect the gastric mucosa. Three mechanisms are involved: reduced secretion of gastric acid, increased secretion of bicarbonate, and cytoprotective mucus, and the maintenance of submucosal blood flow. In the platelets, COX promotes synthesis of TXA2, which stimulates platelet aggregation. In blood vessels, COX promotes synthesis of prostacyclin, which causes vasodilation. In the kidneys, COX catalyzes synthesis of PGE2 and PGI2, which promote vasodilation and therefore maintain renal blood flow. In the brain, COX-derived prostaglandins mediate fever and contribute to the perception of pain. In the uterus, COX-derived prostaglandins help promote contractions at term. It's important to help appreciate that prostaglandins, prostacyclin, and TXA2 act locally. These compounds do not affect sites distant from where they are made. Cyclooxygenase has two forms, named cyclooxygenase 1 and 2, or COX1 and COX2, respectively. COX1 is found in practically all tissues, where it mediates housekeeping chores. Important among these are protecting the gastric mucosa, supporting renal function, and promoting platelet aggregation. In contrast, COX2 is produced mainly at the sites of tissue injury, where it mediates inflammation and sensitizes receptors to painful stimuli. COX2 is also present in the brain, the kidneys, blood vessels, and the colon. Because COX1 primarily mediates beneficial processes, whereas COX2 primarily mediates harmful processes, COX1 has been dubbed the good COX, while COX2 is considered the bad COX. Some important functions of both COX1 and 2 are discussed here in Table 55.1, which is our first section for us to hit pause so you can review the different aspects. Having established the roles of COX1 and 2, we can now predict the effects of drugs that inhibit these enzymes. Inhibition of COX1, or good COX, largely results in harmful effects: gastric erosion and ulceration, bleeding tendencies, renal impairment, protection against myocardial infarction and strokes, which results largely in the beneficial effects. Suppression of inflammation, alleviation of pain, reduction of fever, protection against colorectal cancer via the inhibition of COX-2, renal impairment, promotion of MI and stroke. So that brings us to the classification of cyclooxygenase inhibitors. The cyclooxygenase inhibitors fall into two major categories: drugs that have anti-inflammatory properties and drugs that lack anti-inflammatory properties. Agents in the first group are referred to as nonsteroidal anti-inflammatory drugs, also known as NSAIDs. Representative members include are aspirin, ibuprofen, naproxen, and psilocybin. The second class consists of just one drug, Tylenol. Tylenol can reduce pain and fever, but it does not suppress any inflammation. The NSAIDs can be subdivided also into two other groups, a first generation and second generation of NSAIDs. The first generation agents inhibit COX-1 and 2. The second generation inhibits COX-2 only. Because the first generation agent inhibits both isoforms, they are unable to suppress pain and inflammation without posing a risk for side effects. In contrast, because of their selectivity for COX-2, the second generation NSAIDs, in theory, can suppress pain and inflammation while causing fewer adverse effects than the first generation NSAIDs. However, in reality, COX-2 inhibitors appear even less safe than the first generation, owing to the increased risk for myocardial infarctions and stroke. The following table, 55.2, shows the principal indications and adverse effects of the first generation NSAIDs, second generation NSAIDs, and Tylenol. So it's another excellent spot to hit pause so you can review kind of the different aspects of each. So we'll talk specifically now on just first generation NSAIDs. First generation NSAIDs, a large and widely used group of drug, inhibit COX-1 and 2. In the US, more than 70 million prescriptions are written annually, and more than 30 billion tablets are sold over the counter. The traditional NSAIDs are used to treat inflammatory disorders, such as rheumatoid arthritis, osteoarthritis, and bursitis. They also help alleviate mild to moderate pain, suppress fevers, and relieve dysmenorrhea. Because they cannot inhibit COX-2 without inhibiting COX-1, first-generation NSAIDs cannot suppress inflammation without posing a risk for serious harm. NSAID-induced ulcers are responsible for more than 100,000 hospitalizations and roughly between 7,000 to 10,000 deaths per year. Aspirin is the oldest member of the family and prototype for the group. So, speaking strictly on aspirin. Aspirin is a highly valuable and effective medication. The drug provides excellent relief of mild to moderate pain, reduces fever, protects against thrombotic disorders, and remains a drug of choice for rheumatoid arthritis and other inflammatory conditions. Despite the introduction to many new NSAIDs, aspirin remains one of the most widely used member of the group, and is the standard against which the others must be compared against. So, its chemistry. Aspirin belongs to a chemical family known as salicylates. All members of this group are derivatives of salicylic acid. Aspirin is produced by substituting an acetyl group into salicylic group, or acid. Because of this acetyl group, aspirin is commonly known as acetylsalicylic acid, or simply ASA. So how does it work specifically? Well, its mechanism of action is a non-selective inhibitor of cyclooxygenase. Most beneficial effects, reductions of inflammation, pain, and fever, result from inhibiting COX-2. One beneficial effect, protection against MI and ischemic stroke, results from inhibiting COX-1. Major adverse effects, gastric ulceration, bleeding, and renal impairment, result from inhibiting COX-1. It's important to note that aspirin is an irreversible inhibitor of cyclooxygenase. In contrast, all other NSAIDs are reversible inhibitors. Because inhibition of cyclooxygenase by aspirin is irreversible, the duration of action depends on how quickly a specific tissue can synthesize new molecules of COX-1 and 2. With other NSAIDs, effects decline as soon as the drug levels fall. Which brings us to our pharmacokinetics. Let's talk strictly about absorption. Aspirin is absorbed rapidly and completely after an oral dose. The principal site of absorption is the small intestine. When administered via a rectal suppository, aspirin is absorbed slowly and blood levels are lower than with an oral dose. Its metabolism, unfortunately, has a very short half-life, only between 15 to 20 minutes, owing to its rapid conversion to salicylic acid, an active metabolite. The rate of inactivation of salicylic acid depends on the amount present. At the lowest therapeutic level, salicylic acid has a half-life of about 2 hours, but high doses may create a half-life that may exceed up to 20 hours. Its distribution. Salicylic acid is extensively bound to the plasma albumin. At therapeutic levels, binding is anywhere between 80 to 90%. Aspirin undergoes the distribution to all body tissues and fluids, including breast milk, fetal tissues, and the CNS. Its excretion, so both salicylic acid and its metabolites are excreted in the kidneys. Excretion of salicylic acid is highly dependent on the urinary pH. Accordingly, by raising the pH of urine from 6 to 8, we can increase the rate of excretion almost fourfold. So, our plasma drug levels. Low therapeutic doses of aspirin produce plasma salicylate levels less than 100 micrograms per ml. Anti-inflammatory doses produce salicylate levels of about 150 to 300 micrograms per ml. Signs of toxicity begin when plasma salicylate levels exceed 200 micrograms per ml, whereas severe toxicity occurs at 400 micrograms per ml. So, what are its therapeutic uses, therefore? Well, it can suppress our inflammation. Aspirin is the initial drug of choice for rheumatoid arthritis, osteoarthritis, and juvenile arthritis. Aspirin is also indicated for other inflammatory disorders, which include rheumatic fevers, tendinitis, and bursitis. The dosage employed to suppress inflammation are considerably larger than doses used for analgesia or reduction of fevers. The use of aspirin and other NSAIDs to treat arthritis is discussed further in Chapter 57. The precise mechanism by which aspirin decreases inflammation have not been established. We do know that the prostanoids contribute to several components of the inflammatory process. Therefore, inhibition of COX-2 provides a partial explanation of anti-inflammatory effects. Other possible mechanisms include the modulation of T cell function, suppression of inflammatory cell infiltration, and stabilization of lysosomes. In analgesia, aspirin is used widely to relieve mild to moderate pain. The degree of analgesia produced depends on the type of pain. Aspirin is most active against joint pain, muscle pain, and headaches. For some forms of postoperative pain, aspirin can be more effective than an opioid. However, aspirin is relatively ineffective against severe pain of visceral origin. In contrast to opioid analgesics, aspirin produces neither tolerance nor physical dependence. In addition, aspirin is safer than opioids. Aspirin relieves pain primarily through the actions in the periphery. At sites of injury, prostanoids sensitize pain receptors to mechanical and chemical stimulation. Aspirin reduces pain by inhibiting COX-2, thereby suppressing the prostanoid production. In addition to this peripheral mechanism, aspirin works in the CNS to help relieve pain. Its therapeutic response in the reduction of fever. Aspirin again is a drug of choice for reducing temperatures in febrile adults. However, because of this risk for Ray's syndrome, aspirin should not be used to treat fever in children. Although aspirin readily reduces fever, it will not lower normal body temperature, nor will it lower temperature that has become elevated in response to physical activity or to a rise in environmental temperature. Body temperature is regulated by the hypothalamus, which maintains a balance between heat production and heat loss. Fevers occur when the set point of the hypothalamus becomes elevated, causing the hypothalamus to increase heat production and decrease heat loss. Set point elevation is triggered by local synthesis of prostaglandins in response to endogenous pyrogens. Aspirin lowers that set point by inhibiting that COX-2 and therefore inhibits pyrogen-induced synthesis of prostaglandins. Its therapeutic use in dysmenorrhea. Aspirin can provide relief from primary dysmenorrhea. Benefits derive from inhibiting prostaglandin synthesis in the uterine smooth muscle. Some of the newer aspirin-like drugs, including ibuprofen and naproxen, are superior to aspirin for dysmenorrhea. The efficacy of the newer drugs is attributed to the greater ability to inhibit COX in the uterus. Its next therapeutic use includes the suppression of platelet aggregation. Synthesis of TXA2 in platelets promotes aggregation. Aspirin suppresses platelet aggregation by causing irreversible inhibition of COX-1, the enzyme that makes TXA2. Because platelets lack the machinery to synthesize new COX-1, the effects of a single dose persists for a life of the platelet, which is about 8 days. There is a large body of evidence demonstrating that aspirin, through its antiplatelet actions, can benefit a variety of patients. According to the FDA, recommended wider use of aspirin for antiplatelet effects. Professional labeling now recommends daily aspirin for men and women with the following diseases. Patients who've had a history of ischemic strokes, TIAs, acute MIs, past MIs, chronic stable angina, unstable angina, angioplasty, and other revascularized procedures. According to a review published in the Journal of the American Medical Association, an aspirin dose for the prevention of cardiovascular disease, a dose between 75 to 81 milligrams per day of these indications, is adequate. Higher doses, which is commonly prescribed in these circumstances, offer no greater protection, but will increase the risk for GI bleeding. In addition to these applications, aspirin can be taken by healthy people for primary prevention of both MIs and strokes. However, more recent studies show that aspirin provides less protection against cardiovascular disease than once thought. The potential small benefits must be weighed against the major risk of aspirin use, again, namely that GI hemorrhage. Therefore, to determine the net benefit of primary prevention for any man or woman, we must determine his or her individual risk for a GI bleed and compare that risk with his or her individual risk for having a cardiovascular event. Many organizations, including the American Heart Association, the American Thoracic Society, and the European Society of Cardiology, recommend against the use of aspirin for primary prevention of cardiovascular disease unless the patient has a 10-year risk greater than 10%. So how do we calculate that 10-year risk for a cardiovascular risk or event? Well, there is a chart calculator here at this website from the NIH. So here's a good spot to hit pause and you can take a look at that website specifically. Finally, its next section is its next therapeutic use is the cancer prevention. So, in colorectal cancer, there is good evidence that regular use of aspirin decreases the risk for colorectal cancer, even when the dosage is low. Results from the Nurses' Health Study showed that a regular use of high-dose aspirin, as much as 650 milligrams per day or more, can reduce the risk for colorectal cancer. This dosage is much greater than that used to prevent cardiovascular disease, and therefore poses a significant risk for bleeding. In fact, for every one or two cancers prevented, high-dose aspirin would cause 8 additional serious bleeds. Fortunately, more recent studies indicate that a low-dose aspirin is effective too. For example, a recent study showed that in 2010, they indicated that taking a lower dose aspirin, between 75 to 300 milligrams per day, for more than 5 years, reduced the incidence of colorectal cancer, as well as mortality from colon cancer, by as much as 35%. At these low doses, the benefits of cancer protection may well outweigh the risk for possible bleeding and other adverse events. Aspirin protects against colorectal cancer, probably by inhibiting COX-2. In animal models, COX-2 promoted the tumor growth and metastasis, and inhibition of COX-2 seemed to slow tumor growth. In humans, most colorectal cancers expressed COX-2. Furthermore, protection by aspirin is limited to colon cancers that have a high COX-2 level. Aspirin does not protect against colon cancers with little or no COX-2. So, its therapeutic use then in other cancers. Available data also suggested that protection may not be limited to strictly colorectal cancer. Results of a meta-analysis reported again by The Lancet effects of daily aspirin on long-term risk of death due to cancer. Analysis of individual patient data from randomized trials showed that daily low-dose aspirin reduced the risk for death from all solid tumors by as much as 34%, but does not reduce the risk for death from hematologic cancers. In addition, The Lancet also published an additional article in 2012 that analyzed 5 randomized controlled trials. During that analysis, it determined that the use of aspirin may also prevent distant metastasis of tumors that had already existed. Earlier studies have shown protection against specific cancers. In a study involving men older than 60 years, daily use of aspirin and other NSAIDs was associated with a 50% decrease in the incidence of prostate cancer. In a study involving about just shy of 3,000 women, aspirin appeared to reduce the risk for breast cancer, especially among women with hormone receptor positive tumors, and among those who took 7 or more aspirin tablets a week. In another study, taking aspirin at least 3 times a week for at least 6 months was associated with a 40% reduction in the incidence of ovarian cancer. In contrast to these positive results, from the Women's Health Study Group found no protection with low-dose aspirin against cancer of the breast, colon, or any other tissue. The reason for discrepancy, however, was not clear. 4 additional studies are currently underway to examine various effects of aspirin on the cancer prevention. So, for all its therapeutic uses, there are adverse effects. When administered short-term in analgesic or antipyretic doses, aspirin rarely causes any kind of serious adverse effects. However, toxicity is common when treating anti-inflammatory disorders, which require long-term high-dose treatments. So, the biggest one is our gastrointestinal effects. The most common side effects are gastric distress, heartburn, and nausea. These can be reduced by taking aspirin with food or a full glass of water. Occult GI bleeding occurs often in most cases, and the amount of blood lost each day is insignificant. However, with chronic aspirin use, cumulative blood loss can produce anemia. Long-term aspirin, even in low doses, can result in life-threatening gastric ulceration, perforation, and bleeding. Ulcers result from 4 causes: an increased secretion of acid and pepsin, decreased production of cytoprotective mucus and bicarbonate, decreased submucosal blood flow, and finally the direct irritant action of aspirin on the gastric mucosa. The first 3 occurs secondary due to the inhibition of COX-1. Direct injury to the stomach is most likely with aspirin preparations that dissolve slowly. Owing to the slow dissolution, particulate aspirin becomes entrapped in folds of the stomach, wall, causing prolonged exposure to a high concentration of the drug. Because aspirin-induced ulcers are often asymptomatic, perforation and upper GI hemorrhage can occur without any premonitory signs. Factors that increase the risk for ulceration may also include advanced age, history of peptic ulcer disease, a previous intolerance to aspirin or other NSAIDs, and alcohol abuse. So, what can we do to prevent stomach ulcers? According to an expert panel convened in 2008 by the College of Gastroenterology, as well as the College of Cardiology, a prophylaxis with a proton pump inhibitor or PPI is recommended for patients at risk, including those with a history of peptic ulcers or taking glucocorticoids, as well as the older patient population. Proton pump inhibitors reduce ulcer generation by suppressing production of gastric acid. In addition to a PPI, other drugs that may be considered include histamine 2 receptor antagonists and misoprostol. COX-2 inhibitors may also be tried instead of the traditional NSAIDs because they are thought to produce fewer GI side effects. Because many ulcers are caused by the infection of H. pylori, the panel recommends that patients with ulcer histories undergo testing and treatment for H. pylori before starting long-term aspirin use. Treatment of NSAID-induced ulcers will be discussed further in Chapter 62. So, another side effect includes bleeding. Aspirin promotes bleeding by inhibiting platelet aggregation. Taking just two 325 milligram aspirin tablets can double bleeding time for about 1 week. Because of its effects on platelets, aspirin is contraindicated for patients who have a history of bleeding disorders. To minimize blood loss during childbirth and elective surgery, high-dose aspirin should be discontinued at least 1 week prior to these procedures. There's no need to stop aspirin before procedures with a low risk for bleeding. In most cases, use of low-dose aspirin to protect against thrombosis should not be interrupted for elective surgery and dental procedures. Caution is needed when aspirin is used in conjunction with anticoagulants. In a patient who is taking daily aspirin, blood pressure increases the risk for hemorrhagic stroke. Even though aspirin protects against ischemic stroke, to reduce risk for hemorrhagic stroke, a blood pressure should be 150/90 before starting daily aspirin. And that number may have changed at this point to, I believe, 140/80. Renal impairment is another side effect. Aspirin can cause acute, reversible impairment of the renal function, resulting in salt and water retention and edema. Clinically, significant effects are most likely in patients with additional risk factors: your elderly, existing renal impairment, hypovolemia, hepatic cirrhosis, or heart failure patients. Aspirin impairs renal function by inhibiting COX-1, thereby depriving the kidney of prostaglandins needed for their normal day-to-day function. Development of renal impairment is signaled by reduced urine output, weight gain despite the use of diuretics, and the rapid rise in serum creatinine, as well as BUN. If any of these occur, aspirin should be withdrawn immediately. In most cases, kidney function then returns to their baseline level. The risk for acute renal impairment can be reduced by identifying high-risk patients and treating them with the smallest dosage possible. In addition to its acute effects on renal function, aspirin may pose a risk for renal papillary necrosis, as well as other types of renal injury when used long-term. Which brings us now to salicylism, which is a syndrome that begins to develop when aspirin levels climb just slightly above the therapeutic level. Overt signs include tinnitus, sweating, headaches, and dizziness. An acid-base disturbance may also occur. If salicylism develops, aspirin needs to be withheld until the symptoms subside. Aspirin should then resume, but with a small reduction in dosage. In some cases, Development of tinnitus can be used to adjust aspirin dosage. When tinnitus occurs, the maximal acceptable dose has been achieved. However, this guideline may be inappropriate for older patients because they may fail to develop tinnitus even when aspirin levels become toxic. Acid-base disturbances result from the effects of aspirin on respirations. When administered in high therapeutic doses, aspirin acts on the CNS to stimulate breathing. The resultant increase in CO2 loss produces respiratory alkalosis. In response, the kidneys excrete more bicarbonate. There is also a subsequent buildup of acids, producing a resultant metabolic acidosis. Therefore, many patients that present with salicylate toxicity will have a mixed acid-base imbalance. Rey syndrome. The use of aspirin in children that are under the age of 18 may be associated with something called Rey syndrome. This syndrome is a rare but serious illness of childhood that has a mortality of up to 20 to 30%. Characteristic symptoms include encephalopathy and fatty liver degeneration. Epidemiology reports suggest that there is a relationship between Rey syndrome and the use of aspirin by children who have influenza or the chickenpox. Although there is a direct causal link between aspirin and Rey syndrome, which was never fully established, the CDC recommends that aspirin be avoided by children and teenagers suspected of having the flu or chickenpox. In response to this recommendation, aspirin was removed from most products intended for children, and aspirin use by children declined sharply. As a result, Rey syndrome essentially vanished. The incidence declined from its highest 555 cases in 1980 to no more than 2 cases per year since 1994. If a child with chickenpox or the flu needs an analgesic antipyretic, Tylenol is the treatment or option of choice. Adverse effects associated with use while pregnant. Aspirin does pose a risk to the pregnant patient and her fetus. Accordingly, the drug is classified in the pregnancy category risk D. There is evidence of human fetal risk, but the potential benefit from the drug during pregnancy may outweigh the potential for harm. The principal risk to the pregnant woman is anemia due to GI blood loss and postpartum hemorrhage. In addition, by inhibiting the prostaglandin synthesis, aspirin may suppress spontaneous uterine contractions and may therefore prolong her labor. Also, please keep in mind, aspirin does cross the placenta and may have adverse effects on the fetus. Because prostaglandins help keep the ductus arteriosus patent, inhibition of prostaglandin synthesis by aspirin may induce premature closure of the ductus arteriosus. Aspirin use has also been associated with a low birth weight, stillbirth, and renal toxicity, intracranial hemorrhage in preterm infants, as well as neonatal death. Hypersensitivity reactions. Hypersensitivity develops in about 0.3% of aspirin users. Reactions are most likely in the adults who have a history of asthma, rhinitis, or nasal polyps. Hypersensitivity reactions are uncommon in children. The aspirin hypersensitivity reaction begins with profuse watery rhinorrhea and may progress to generalized urticaria, bronchospasms, laryngeal edema, and shock. Despite its resemblance to severe anaphylaxis, this reaction is not allergic and is not mediated by the immune system. So what causes these reactions? Because individuals who react to aspirin are also sensitive to most other NSAIDs, we believe that the reactions are due to the inhibition of COX-1, which triggers production of leukotrienes, which in turn causes bronchospasms, hives, and other signs of hypersensitivity. However, if this is the mechanism, it remains unclear why hypersensitivity is limited mainly to adults, with the predisposing conditions noted earlier. As with severe anaphylaxis or anaphylactic reactions, epinephrine is the treatment of choice. Hypersensitivity to aspirin is considered a contraindication to using other drugs with aspirin-like properties. Nonetheless, if an aspirin-like drug must be taken, four such drugs are probably safe. One of these is celecoxib, which is a selective for COX-2. Another, meloxicam, is somewhat selective for COX-2, but only at low doses. And finally, Tylenol and salicylate, which are only weak inhibitors of COX-1. Which brings us now to the cardiovascular events. In contrast to all other NSAIDs, aspirin does not increase the risk for thrombotic events, which would include MI and ischemic stroke. In fact, when taken in low doses, aspirin protects against these events. ED, or erectile dysfunction. Daily use of aspirin and other NSAIDs may be associated with a 22% increase in the risk for erectile dysfunction. A study shown that almost 81,000 men in California uh, came back positive with a causal relationship, but it hasn't been fully established. So, a summary of precautions and contraindications, therefore. Aspirin is contraindicated in a patient who has PUD, bleeding disorders, and hypersensitivity to aspirin itself or any other NSAID. In addition, the drug should be used with extreme caution if you are pregnant and by any child who may have the chickenpox or the flu. Caution also needs to be exercised when treating the older adult patient population, your current smokers or ex-smokers, patients with a history of H. pylori, heart failure, hepatic cirrhosis, hypovolemia, renal dysfunction, asthma, hay fever, chronic urticaria, nasal polyps, or a history of alcoholism. Again, aspirin should be withdrawn 1 week before an elective surgery or the anticipated date of childbirth. So here's an excellent spot to hit pause so you can see the patient-centered care across the lifespan regarding NSAIDs. And I'll leave that up for just a moment. Other drug interactions. Because of its widespread use, aspirin has been reported to interact with many other medications. However, most of these interactions have little clinical significance. Significant interactions, however, are going to be addressed here specifically. And we'll touch base on the first and most important, I would say, which would be our Coumadin, heparin, and other anticoagulants. Aspirin's most important interaction with anticoagulants, because aspirin suppresses platelet function and can decrease prothrombotic production, aspirin can intensify the effects of Coumadin, heparin, and other anticoagulants. Furthermore, because aspirin can initiate gastric bleeding, augmenting anticoagulant effects can increase the risk for further gastric hemorrhage. So the combination of aspirin with anticoagulants must be used with care, even when aspirin is taken in a low dose to reduce the risk of a thrombotic event. When taken with glucocorticoids, like aspirin, glucocorticoids promote gastric ulceration, so as a result, the risk of ulcers is increased when the drugs are combined, as may happen when treating arthritis. To reduce the risk of gastric ulcerations, a patient needs to be given either a PPI or a H2RA for prophylaxis. Again, our patients who drink alcohol. Combining alcohol with aspirin or other NSAIDs increases the risk for gastric bleeding, so it's always good to alert the public of that risk. And the FDA now requires that there are labels that include a warning that if you consume 3 or more alcoholic drinks every day, ask your doctor whether or not you should be taking aspirin or other pain relievers that are aspirin related, because they may cause stomach bleeding. And again, your other interactions with non-aspirin NSAIDs. So your ibuprofen, naproxen, and other non-aspirin NSAIDs all can reduce the antiplatelet effects of aspirin by blocking access to aspirin to COX-1 and platelets. This is important to remember because in patients who are taking a low-dose aspirin to prevent an MI or ischemic stroke, other NSAIDs may negate aspirin's benefits. Because immediate release aspirin produces a complete platelet inhibition about 1 hour after a dose, we can prevent interference by giving an aspirin about 2 hours before giving any other NSAID. Of course, we could eliminate interference entirely by using high-dose aspirin rather than another NSAID when the conditions call for NSAID therapy. When taken with an ACE or an ARB, similar to aspirin, our ACE inhibitors and ARBs can impair renal function. In suspected or in susceptible patients, combining aspirin with drugs in either class may increase the risk for acute renal failure. High-dose aspirin needs to be avoided in patients who are taking either an ACE or an ARB. However, low-dose aspirin may be taken for their antiplatelet effects, and that can be continued. When taking vaccines, aspirin and other NSAIDs may blunt the immune response to vaccines. So accordingly, these drugs should not be used routinely to prevent vaccination-associated fever or pain. Which brings us now to acute poisoning. An aspirin overdose is a common cause of poisoning. Although it's rarely fatal in adults, aspirin poisoning may be lethal in a child. The lethal dose for adults is anywhere between 20 to 25 grams, where in contrast, as little as 4 grams may kill a child. So what would be your signs and symptoms? Well, initially, aspirin overdose produces a state of compensated respiratory alkalosis, the same state that is seen in mild salicylism. As the poisoning, however, progresses, respiratory excitation is replaced with respiratory depression. Acidosis, hyperthermia, sweating, and dehydration start to become more prominent, and the electrolyte imbalance starts to become more likely, which leads you to having stupor and potential coma result from the effects of the CNS, and death usually results from respiratory failure. So how do we treat that? Aspirin poisoning is an acute medical emergency that requires hospitalization. The immediate threats to life are respiratory depression, hyperthermia, dehydration, and acidosis, so treatment is considered largely supportive. If respiration is inadequate, then the patient needs to be intubated. External cooling can be helped to reduce hyperthermia. IV fluids can be given to help correct the dehydration, and the composition of the fluids can be determined by electrolyte and acid-base status. Slow infusion of bicarbonate can be given to reverse acidosis. So there are several measures that we can use to reduce further GI absorption of aspirin as well, which would include a gastric lavage or giving activated charcoal. Alkalinizing of the urine with bicarbonate also accelerates the excretion of aspirin and salicylates. So if necessary, hemodialysis or peritoneal dialysis can be used to remove any excess salicylates. Which finally brings us to our formulations. Aspirin is available in multiple formulas, including the plain and buffered tablets, enteric-coated preparation, and tablets used to produce a buffered solution. These different formulations reflect efforts to increase rates of absorption and decrease gastric irritation. And for the most part, the clinical utility of the more complex formulas is no greater than that of the plain aspirin tablets. So I won't specifically jump into each and every single one of these, mostly because we're familiar with aspirin tablets. Um, but feel free to hit pause. I'll make sure you have plenty of time to, read each section. But for instance, there is the plain aspirin tablet. Then we also have the buffered aspirin tablet. Then there's also a buffered aspirin solution, the most common enteric-coated preparation. We also have the timed release tablets. And everyone's favorite rectal suppository. So, dosage and administration. Aspirin is always administered in That is a lie because we just saw that there's a rectal suppository. But it says here, aspirin is almost always administered by mouth. Gastric irritation can be minimized by dosing with water and or food. Dosage again depends on age and the patient and the condition being treated. Adult and pediatric doses for major indications are shown here in this following table. And again, here's an excellent spot to hit pause so you can see different dosages. And that brings us to our non-aspirin, first-gen, non-steroidal anti-inflammatory drugs. In attempts to produce an aspirin-like drug with fewer GI, renal, and hemorrhagic effects than aspirin, the pharmaceutical industry has produced a large number of drugs with actions that are very similar to aspirin. In the US, there's more than 20 non-aspirin NSAIDs that are available. Similar to aspirin, all the other first-generation NSAIDs inhibit both COX-1 and 2. However, in contrast to aspirin, which causes irreversible inhibition of cyclooxygenase, the other traditional NSAIDs cause reversible inhibition. All of these drugs have anti-inflammatory, analgesic, and antipyretic properties. In addition, they all can cause gastric ulceration, bleeding, and renal impairment. Although the intensity of these effects may be less than with some other agents, patients who are hypersensitive to aspirin are likely to experience a cross hypersensitivity with other NSAIDs. For most NSAIDs, safety during pregnancy has not been established, and therefore the use by a pregnant woman is considered or should be discouraged rather. So here's a list of all the other clinical pharmacology of oral nonsteroidal anti-inflammatory drugs that are available, at least here in the United States. It's a good spot to hit pause if you're unfamiliar with all the other types, and I'm sure we'll touch base on several of them. So, the principal indication for non-aspirin NSAIDs are usually for rheumatoid arthritis and osteoarthritis. In addition, certain NSAIDs are used to help treat fevers, bursitis, tendinitis, mild to moderate pain, and dysmenorrhea. In contrast to aspirin, the non-aspirin NSAIDs do not protect against MI or strokes. In fact, they all increase the risk for a thrombotic event. For the NSAIDs as a group, the increase in cardiovascular risk is considered relatively low, only about 12%. The risk is highest with indomethacin at 71%, sulindac at 41%, and meloxicam at 37%. However, although the increase in risk with these drugs appears high, it pales in comparison with smoking, which increases cardiovascular risk by 200% to 300%. So, to help minimize cardiovascular risk, your non-aspirin NSAIDs should be used in the lowest effective dosage for the shortest time needed. Also, these drugs should not be used before any type of coronary artery bypass graft or CABG surgery, or for 14 days thereafter. Other measures to help reduce the risk are discussed later under the American Heart Association statement on cyclooxygenase inhibitors in chronic pain. Although individual NSAIDs differ chemically, pharmacokinetically, and to some extent pharmacodynamically, all are similar clinically. They all produce essentially equivalent anti-inflammatory effects, and they all present a similar risk for serious adverse effects. Again, are GI ulceration, bleeding, renal impairment, MIs, and strokes. However, for reasons that aren't fully understood, individual patients may respond better to one agent than another. Furthermore, individual patients may tolerate one NSAID better than another. Therefore, to optimize therapy for patients, trials with more than one NSAID still need to be taken and still need to be done. So, we'll jump right into our first medication, a very common ibuprofen, also known as Advil, Motrin, and Caldolor. It's the prototype of the propionic acid derivative. Other members in the family are shown in Table 55.4 and discussed individually below. Similar to aspirin, ibuprofen inhibits cyclooxygenase and has anti-inflammatory, analgesic, and antipyretic actions. The drug is used to treat mild fever, mild to moderate pain, and arthritis. In addition, ibuprofen appears superior to most other NSAIDs for the relief of primary dysmenorrhea, presumably because it produces good inhibition of cyclooxygenase in uterine smooth muscle. During clinical trials, ibuprofen was highly effective at promoting closure of the ductus arteriosus in preterm infants, a condition for which indomethacin is the current treatment of choice. Ibuprofen is generally well tolerated, and the incidence of adverse effects is low. The drug produces less gastric bleeding than aspirin, and less inhibition of platelet aggregation as well. However, ibuprofen is among the safer NSAIDs for the use with anticoagulants. Very rarely, ibuprofen has been associated with Stevens-Johnson syndrome, a severe hypersensitivity reaction that causes blistering of the skin, the mucous membranes, and it could result in their potential scarring, blindness, and even death. Similar to other non-aspirin NSAIDs, ibuprofen does pose a risk for MI or strokes. Its oral preparation and dosage. I will let you hit pause here. There are several dosages that you can get over the counter, as well as if really needed via prescription. There's pediatric dosages. Again, please hit pause. The dosages for adults, for instance, for arthritis, are different than for primary dysmenorrhea, which is different for mild to moderate pain. Again, these are sections, just hit pause. It's a lot, and reading it to you is, I don't think, as beneficial as it may sound. Oral ibuprofen is also available in fixed-dose combos, which would be your ibuprofen oxycodone, your ibuprofen hydrocodone, and ibuprofen famotidine, which is used for the treatment of rheumatoid arthritis, osteoarthritis, while reducing the risk for GI ulcers. Alright, which brings us to your non-acetylated salicylates. So that would be our magnesium salicylate, sodium salicylate, and salicylate. Again, the similarities to aspirin. The non-acetylated salicylates are similar to aspirin in most respects. Like aspirin, these drugs inhibit COX-1 and 2 and are employed to treat arthritis, moderate pain, and fever. The most common adverse effects, again, include our GI disturbances. As with aspirin, these drugs should not be given to children who have the chickenpox or flu, owing to the possibility of precipitating Rey syndrome. So how are they different from aspirin? Well, they differ from aspirin in which the non-acetylated salicylates cause little or no suppression of platelet aggregation. So as a result, the drugs can't protect you against MIs or strokes, and may actually increase that risk. Because of their sodium content, sodium salicylate should be avoided in a patient who is on a sodium-restricted diet. Magnesium salicylate may accumulate to a toxic level in a patient with chronic renal insufficiency, and therefore should not be used by those individuals. Salicylate is a prodrug that breaks down to release two molecules of salicylate in the alkaline environment of the small intestine. Because the stomach is not exposed to salicylate, salicylate produces less gastric irritation than aspirin. Which brings us back to our different types of dosages. Again, here's that spot. Go ahead and hit pause. There are many different dosages for many different uses. So go ahead and read over that. Phenoprofen, also known as Nalfon, belongs to the propionic acid family of NSAIDs. Like other NSAIDs, the drug inhibits synthesis of prostanoids, thereby causing anti-inflammatory, analgesic, and antipyretic effects. Phenobarbital is indicated for arthritis and mild to moderate pain, and its most adverse effects include GI disturbances. Again, this is an oral tablet you can take. Again, hit pause to read at your dosages. It may be used again for rheumatoid arthritis and osteoarthritis, as well as mild to moderate pain. Which brings us to flurbiprofen, which is chemically related to ibuprofen and other derivatives of the propionic acid. Again, the drug is used for arthritis and has been used investigationally for bursitis, tendinitis, moderate pain, fever, and primary dysmenorrhea. Again, our most common adverse effects would be our GI disturbances. The risk for GI's serious effects, such as ulceration, perforation, and hemorrhage, may actually be greater than with the usage of an ibuprofen. Like other NSAIDs, flurbiprofen can exacerbate renal impairment and pose a risk for MIs and strokes. It's an oral tablet, and the normal dosage ranges between 2 to 300 milligrams and can be divided throughout the day. Ketoprofen. Ketoprofen belongs again to the propionic acid family of NSAIDs. It inhibits the synthesis of prostanoids and has anti-inflammatory, analgesic, and antipyretic effects. It's used for rheumatoid arthritis, osteoarthritis, mild to moderate pain, and primary dysmenorrhea. Adverse effects include dyspepsia, nausea, vomiting, and abdominal pain. It's an oral capsule and has several dosages, and again, it's a spot you need to hit pause for. Me reading all these dosages again, I don't think will help you keep them in mind in all reality. If anything, I think it might confuse more people than help. Which brings us to naproxen. Naproxen, also known as Aleve, is another member of the propionic acid family of NSAIDs, and still very popular today. It's highly selective for COX-1. The drug has a prolonged half-life and can be administered less frequently than other propionic acid derivatives. Naproxen is approved for arthritis, bursitis, tendinitis, primary dysmenorrhea, fever, and mild to moderate pain. Similar to other NSAIDs, the drug acts primarily by inhibiting cyclooxygenase. It does have some adverse effects which are a little different. Naproxen is among the better tolerated NSAIDs. The most common adverse effects are our GI disturbances. And like other NSAIDs, the drug can compromise renal function and may increase the risk for MI and stroke. However, because naproxen is COX-1 selective, the risk for MI and stroke appear lower than with other traditional NSAIDs. Your bleeding time can be prolonged due to the reversible inhibition of platelet aggregation. Naproxen or Aleve is sold in many different preparations, dosages, and formulas. So again, this is the spot you need to hit pause for. But there is also a combo drug of naproxen with a medication called esomeprazole, also known as Vimovo. Vimovo is a fixed-dose combo drug of naproxen plus esomeprazole, which is a PPI that helps block the production of gastric acid and therefore protects against naproxen-induced ulcers. Vimovo has a delayed-release tablet, which is available in 2 different dosages. For patients who have osteoarthritis, rheumatoid arthritis, and ankylosing spondylitis, it's usually 1 tablet twice daily. Oxaprocin. Oxaprocin, also known as Dapro, still belongs in the family of propionic acid family of NSAIDs. Its approved use includes rheumatoid arthritis and osteoarthritis. Similar with other NSAIDs, the benefits derive from inhibiting the synthesis of prostanoids. And like other propionic acid derivatives, oxaprocin is generally well tolerated. The drug, however, has an unusual long half-life, anywhere between 42 to 50 hours, and therefore can be given just once a day. It's usually a larger dose, anywhere between 600 milligrams to 1800 milligrams once daily. Diclofenac. Diclofenac, or Voltaren, is another approved medication for rheumatoid arthritis, osteoarthritis, ankylosing spondylitis, mild pain, primary dysmenorrhea, and migraines. As with all our other NSAID and anti-inflammatory, analgesics, and antipyretic effects that result from inhibiting cyclooxygenase, it is well absorbed after oral administration and undergoes an extensive metabolism on its first pass through the liver, so as much as 40 to 50%. However, in the blood, 99.5% of the drug is protein bound, usually to albumin. It's metabolized by the liver and excreted in the urine. And the most common adverse effects are abdominal pain, dyspepsia, and nausea. By impairing renal function, diclofenac can cause fluid retention, which can exacerbate hypertension and heart failure. It can also cause severe liver injury, even with topical therapy. So accordingly, patients should receive periodic tests of liver function and should be instructed to report manifestations of any kind of liver injury, so jaundice, fatigue, nausea. And if the injury is diagnosed, the medicine needs to be discontinued. Again, it's supplied in many different oral tablets, as well as extended release and liquid-filled capsules, as well as a powder. So again, please hit pause, take a look. It's good to know, but there's so many dosages that we're going to be talking about today that if you're not looking at it physically, I feel like you will not remember it. It's topical use of diclofenac. Again, there's also a topical formula. If anything, there's 3 topical formulas. So there's a Voltaren gel, a Flector patch, and a Pensed solution. And that's for the treatment of pain and inflammation. Again, that Voltaren gel is used for osteoarthritis. The Flector patch is usually for like minor pains, and Pensed is for osteoarthritis of the knee. There's even a 4th formula, Solarises, which is used for actinic keratosis, which we'll discuss more in chapter 85. Topical diclofenac is more expensive than the oral, but it's also safer with the topical therapy. And that's because your blood levels are only about 5% of those achieved with an oral therapy, and therefore the risk for a systemic toxicity is considered low. Your efficacy of topical diclofenac appears about equal to that of an oral therapy. Whether the topical diclofenac shares the drug's interactions has not yet been fully determined. However, the Voltaren gel, which was the first prescription topical NSAID for treating pain and inflammation, when the application is done, for instance, to the knees, elbows, and other amendable joints, for joints of the lower extremities, the dosage is usually 4 grams of gel that's applied several times per day, up to 4 times. They do say, though, that you should not exceed 32 grams per day of gel, and that gel needs to be protected from the sunlight. Local dermatitis is the principal adverse effect of the Voltaren gel, which takes us now to that Flector patch, which is the first prescription NSAID patch indicated for pain of strains, sprains, and contusions. They want you to put 1 patch over the injury twice a day. And again, you shouldn't be wearing this patch while you're showering or bathing, and local reactions include pruritus, dermatitis, burning, which are the principal adverse effects. Which leads us to the Pensed, which is a solution of the diclofenac sodium, which can be used to facilitate skin penetration. The product has only one indication, that's the osteoarthritis of the knee. They say that the efficacy is equal to that of the oral dose, and again, they want you to dose it about 4 times a day, which is these little droplets that you put on the knee. So they say that 40 drops are spread around the knee and then kind of like rubbed in. However, you'll have that topical reaction such as dry skin, erythema, induration, pruritus, contact dermatitis, and that systemic effects are considered minimal. Patients may experience, though, a garlicky odor or taste owing to the DMSO that's associated with that medicine. Again, they don't want you to use the droplet and not expose it to sunlight, whether it's natural or artificial. So you have to educate your patients to wear long sleeve clothing, things along that nature. Which brings us to diclofenac misoprostol, also known as Arthrotec. The oral diclofenac is a combo drug with misoprostol, which is still available under the trade name of Arthrotec. Misoprostol is a prostaglandin analog that can help protect against NSAID-induced ulcers. This combo product is approved for patients with rheumatoid arthritis or osteoarthritis who have a high risk for NSAID-induced gastric or duodenal ulcers. So, in patients with this arthritis, the combination is as effective as the medication alone, just with less GI ulceration effects. The most bothersome, however, side effect to taking on the combo drug is having diarrhea. Misoprostol can also induce uterine contraction, so the product is contraindicated for use during pregnancy. There's several different dosage strengths. Again, hit pause to take a look at them. Diflunisal. Diflunisal is a derivative of a salicylic acid. However, unlike the other salicylates, diflunisal is not converted to silicic acid in the body. The drug is indicated for mild to moderate pain, rheumatoid arthritis, and osteoarthritis. Like other NSAIDs, the drug inhibits prostaglandin synthesis and can cause GI disturbances, suppression of platelet aggregation, and renal impairment, as well as increase the risk for MIs or stroke. It's got a prolonged half-life of 11 to 15 hours and can be taken 2 to 3 times a day. Again, the dosage in tablets, hit pause, take a look. Etodolac. Etodolac is indicated for rheumatoid arthritis, osteoarthritis, and moderate pain. Investigational use includes bursitis and tendonitis. And like other NSAIDs, etodolac produces many of its effects by suppressing the synthesis of prostanoids. The most common adverse effects include dyspepsia, nausea, vomiting, diarrhea, and abdominal pain. It may cause less gastric ulceration and bleeding than some of the other NSAIDs. However, it's very dependent on the dosage. So there's many different dosages for this medication. Hit pause. Indomethacin. Indomethacin has its own actions and uses and is an effective anti-inflammatory agent approved for arthritis, bursitis, tendonitis, and, as it was discussed in Chapter 58, acute gouty arthritis. Although indomethacin is able to reduce pain and fever, it is not routinely used for these effects. That is because it has the potential for toxicity. Its pharmacokinetics. Indomethacin is well absorbed after oral administration and is distributed to all body fluids and tissues. It's metabolized in the liver, and its metabolites and parent drug are both excreted in both urine and feces. Adverse effects are seen in about 35 to 50% of patients, causing about 20% to actually need to discontinue treatment. The most common adverse effects are the severe frontal headache, which occur in almost half the patients who take the medicine. Other CNS effects include dizziness, vertigo, confusion. Seizures and psychiatric changes, such as depression and psychosis, have occurred. Mild GI reactions include nausea, vomiting, indigestion. However, more severe GI effects, including ulceration with perforation and hemorrhage, have also occurred. Hematologic reactions which include our neutropenia, thrombocytopenia, and aplastic anemia, have occurred but are considered rare. Indomethacin suppresses platelet aggregation, so its precaution and contraindication. Because of its adverse effects, indomethacin is generally contraindicated for infants and children younger than 14. Patients who have a history of peptic ulcer disease and women who are pregnant or breastfeeding. Caution is required in patients with seizures and psychiatric disorders, and in patients involved in hazardous activities, and in patients who are receiving other types of anticoagulant therapy. Again, for preparation, dosage, and administration, these capsules are in many different dosages. Just please take a look. Which brings us to our next medication, ketorolac, one that's still pretty popular today. Actions and use, well, ketorolac is a powerful analgesic with minimal anti-inflammatory actions. Pain relief is equivalent to that which is produced by morphine and other opioids. Although ketorolac lacks the serious adverse effects associated with opioids, it nonetheless has serious adverse effects of its own. Accordingly, use should be short-term and restricted to managing acute to moderate to severe pain. Ketorolac is not indicated for chronic pain or for minor aches or discomforts, the usual indication of post-op pain, but which ketorolac can be as effective as morphine. So like other NSAIDs, ketorolac suppresses prostaglandin synthesis. This action is thought to underlie analgesic effects. So, its pharmacokinetics. It can either be administered orally or parenterally, via intramuscularly or IV. The drug's eliminated via the hepatic metabolism and urinary excretion. In the young adult, ketorolac has a half-life anywhere between 4 to 6 hours. However, that may be prolonged in the older patient population who may have renal impairment. Its adverse effects. Ketorolac can cause all the adverse effects associated with other NSAIDs, which include peptic ulcers, GI bleeding or perforation, prolonged bleeding time, renal impairment, hypersensitivity reactions, the suppression of uterine contractions, and premature closure of ductus arteriosus. With concurrent use with other NSAIDs, it even increases the risk of these effects and is therefore contraindicated. Other contraindications include active peptic ulcer disease, history of peptic ulcer disease, or recent GI bleeding, advanced renal impairment, confirmed or suspected intracranial bleeding, or the use before major surgery, history of NSAID hypersensitivity reaction, and use during labor and delivery are all contraindicated. Its preparation and dosage. During oral therapy, we've got 10 milligram tablets. Again, hit pause to see different dosage types and how often we can give it. An intranasal spray is also available. It's not very common, at least not in the hospital setting, and I think it's actually been discontinued at this time. However, IV dosages is still very much a thing in the hospital setting. Which brings us to meclofenamate. Meclofenamate is indicated for rheumatoid arthritis, osteoarthritis, mild to moderate pain, and dysmenorrhea. As with all the other NSAIDs, the benefits derived from inhibiting cyclooxygenase. Therapeutic effects are no better than with other NSAIDs, but adverse GI effects are greater. 3 to 9% of patients experience nausea, vomiting, abdominal pain, and cramps, and worse yet, up to 33% develop diarrhea. Because of this poor benefit to risk profile, meclofenamate is not a drug of first choice. Again, it's available in several different capsules with different dosages for different indications, so please take a look. Mefenamic acid, or Potsdal, is indicated for the relief of primary dysmenorrhea and moderate pain. The principal adverse effect is diarrhea, which can be severe. It's supplied in capsules, and the dosage is usually anywhere between 500 milligrams to 250 milligrams every 6 hours. Take it with milk to reduce GI gastric distress, and treatment should be more than 2 to 3 days. Nabumetone. Nabumetone is a prodrug that undergoes hepatic conversion to its active form, which is the 6-MNA. In contrast to most traditional NSAIDs, 6-MNA inhibits COX-2 more than it does COX-1. Although nabumetone has antipyretic, analgesic, and anti-inflammatory properties, the drug is approved only for osteoarthritis and rheumatoid arthritis. Adverse effects are diarrhea, abdominal cramps, dyspepsia, and nausea. It causes much less GI ulceration than some of the other first-generation NSAIDs, and that's possibly because it is preferential to the inhibition of COX-2. Keep in mind that when you do dosage with food, it may increase the rate of absorption, and that the dosage needs to be reduced in a patient who has renal impairment. But in terms of the dosaging and all that, please take a look. Piroxicam. Piroxicam, also known as Feldene, is another anti-inflammatory, analgesic, and antipyretic. It has properties for all, but is approved only for rheumatoid and osteoarthritis. The drug's most outstanding feature is its very long half-life, which is about 50 hours. Because it is eliminated so slowly, its therapeutic effects can be maintained by just once-a-day dosing. Keep in mind, it's usually better tolerated than an aspirin. However, undesired effects can be seen in up to 46% of patients, and causing between 4 to 12% to even discontinue therapy. And that's because the gastrointestinal reactions are the most common. The incidence of gastric ulceration is about 1%, and similar to aspirin, piroxicam inhibits platelet aggregation and prolongs bleeding time. So it's important to not give the medication more than twice daily due to its long half-life. Sulindac is a prodrug that undergoes conversion to its active form in the body. The drug is approved for rheumatoid arthritis, osteoarthritis, tendonitis, bursitis, and acute gouty arthritis. Principal adverse effects are abdominal distress, dyspepsia, nausea, vomiting, and diarrhea. Gastric ulceration is less common than with some of the other NSAIDs, but like other NSAIDs, Sulindac causes reversible inhibition of platelet aggregation, prolongs bleeding time, and impairs renal function. Tolmetin is approved for rheumatoid arthritis and osteoarthritis. The drug has analgesic and antipyretic properties, but is not employed to relieve fever or pain unrelated to inflammation. Adverse effects can occur between 25 to 40% of patients, causing between 5 to 10 to discontinue treatment. GI effects are most common. Gastric ulceration has occurred, but less frequently than with aspirin. Nonetheless, caution should be exercised in a patient who has a history of PUD. Hypersensitivity reactions are more common than with aspirin. Its effects on the CNS are less severe and less frequent than with indomethacin, and unlike most other NSAIDs, tolmetin does not augment the effects of Coumadin or an oral anticoagulant. Meloxicam. Meloxicam inhibits COX-1 and 2 but shows selectivity for COX-2 at low doses. Like other NSAIDs, the drug has analgesic, anti-inflammatory, and antipyretic actions. Approved indications are osteoarthritis, rheumatoid arthritis, and pauciarticular polyarticular coarse juvenile rheumatoid arthritis. For osteoarthritis, meloxicam is as effective as a first-gen NSAID. Direct comparison with true COX-2 inhibitors have not been made. Despite its COX-2 selectivity, meloxicam has a side effect profile like that of the first-gen NSAIDs. GI effects occur in 20 to 25% of patients, and more serious effects, your GI ulceration, bleeding, perforation, and death, have also occurred. Meloxicam does not suppress platelet aggregation. The prodrug has a long half-life, between 15 to 20 hours, and undergoes elimination in the urine and feces, about 50-50. Meloxicam is available as a tablet or oral solution, and both can be taken with or without food. Again, because of its long half-life, it should be administered once a day. There's also meloxicam that is available in a solumatrix form, or it's I guess a fine particle technology. Um, Pretty much it contains particles of meloxicam that are 10 times smaller than the, I guess, traditional tablets, and this allows for adequate pain control in osteoarthritis at 33% lower doses. Using less drug can decrease also the toxic side effects. However, we now come to our first black box warning in regard to our first-gen NSAIDs. All first-gen NSAIDs are associated with an increased risk for GI bleeding and cardiovascular events, which can lead to hospitalization or even death. Which finally brings us to our second-gen NSAIDs. The COX-2 inhibitors, also known as COXIPs, are developed in the theory that selective inhibition of COX-2 should be able to suppress pain and inflammation while posing little or no risk for GI upset, which would include our gastric ulceration. To some degree, theory and reality agree. COXIPs are just as effective as your traditional NSAIDs at suppressing inflammation and pain, and they pose a somewhat lower risk for GI side effects. However, even with COXIPs, patients can develop clinically significant GI ulceration and bleeding. Furthermore, like the traditional NSAIDs, COXIPs can impair renal function and can therefore cause hypertension and edema. So there might actually be an increase in the risk in MIs or strokes. So that brings us to medication number 1, celecoxib. Celecoxib, or Celebrex, is the first selective COX-2 inhibitor to reach the market. The drug's indicated for osteoarthritis, rheumatoid arthritis, ankylosing spondylitis, juvenile idiopathic arthritis, acute pain, and dysmenorrhea. In addition, it has an off-label use for a rare genetic disorder known as familial adenomatosis polyposis, which predisposed to the development of colorectal cancer. Again, for our patients with arthritis, Celebrex is equal to naproxen at relieving joint pain, stiffness, and swelling. However, owing to concerns about cardiovascular safety, Celebrex is considered a last choice drug for long-term management of pain. It's important to note that Celebrex does not provide the cardiovascular benefit that aspirin offers, because Celebrex does not inhibit COX-1 in platelets, and therefore does not suppress platelet aggregation. So how does that actually work then? Its mechanism of action causes the selective inhibition of COX-2, the COX isoform whose products mediate inflammation and pain. At therapeutic doses, Celebrex does not inhibit COX-1, and COX isoforms whose products protect the stomach help maintain renal function and promote platelet aggregation. So, its pharmacokinetics. It's generally well absorbed after an oral administration. The plasma levels peak in 3 hours, and binding to the plasma protein is considered extensive, as high as 97%. It does, however, undergo hepatic metabolism that's followed by renal excretion. The half-life is about 11 hours. And there are adverse effects. Again, during the pre-marketing trials, Celebrex was considered well tolerated. The discontinuation rate owing to its adverse effects was about 7%, versus the 6% for the placebo. The most common complaint was dyspepsia and abdominal pain. Celebrex does not decrease platelet aggregation and therefore does not promote bleeding. Possible cardiovascular events are the biggest concerns. So, again, we're speaking strictly now on its adverse effects on gastroduodenal ulceration. Because Celebrex does not inhibit COX-1, the isoform of COX that protects the stomach, a low incidence of GI ulceration would be expected. Some data supports this expectation, but others does not. When Celebrex was first approved, conclusions about its safety was based on a 6-month data from the, class trial, which indicated that Celebrex caused less GI toxicity than the conventional NSAID. However, the long term of at least 12-month data from that same study showed no difference in GI toxicity between celecoxib and conventional NSAIDs. Other studies, however, have shown that compared with patients taking conventional NSAIDs, those that did take celecoxib or Celebrex had a lower incidence of endoscopically detectable ulcers and a lower incidence of hospitalization for GI bleeding. So what is the bottom line then? Well, it may actually be safer than the conventional NSAID, especially when they're used in short term. However, convincing data of superior safety is still considered lacking. Like the traditional NSAIDs, celecoxib can be combined with a PPI to reduce complications. Its cardiovascular effects. Again, there is a strong evidence that coxibs, like other non-aspirin NSAIDs, actually increase the risk for MI, stroke, and other serious cardiovascular events. Again, during an APC trial, patients who took anywhere between 400 to 800 milligrams of the medication a day experienced more major fatal or non-fatal cardiovascular events than those that took a placebo. So to minimize that risk, Celebrex should be used at its lowest effective dosage for the shortest amount of time needed. Also, the drug needs to be avoided in patients who have existing heart disease and those who have just underwent a CABG surgery. And it should be used with caution in a patient who has cardiovascular risk factors such as hypertension, diabetes, and dyslipidemia. There's other measures that need to be discussed, but those are further in this chapter. So why is the risk for MI and stroke increased? Well, again, celecoxib does not inhibit COX-1, which is the platelet aggregation, and it's therefore not suppressed. Secondly, because Celebrex inhibits COX-2 in blood vessels, vasoconstriction is increased. Again, these two factors, unimpeded platelet aggregation and increased vasoconstriction, increases the likelihood of a vessel blockage, and after the process of thrombosis has begun. Renal impairment, like all conventional NSAIDs, Celebrex is no different, and it can impair renal function, thereby posing a risk to patients with hypertension, edema, heart failure, and kidney disease. Renal impairment apparently results from inhibiting COX-2. Your sulfonamide allergy. Celebrex contains sulfur molecules and therefore can precipitate an allergic reaction in patients who are allergic to sulfa medications. Accordingly, the drug should be avoided if you have a sulfa allergy. If you are pregnant, Celebrex and other NSAIDs can cause premature closure of the ductus arteriosus. So, accordingly, these drugs are contraindicated during the 3rd trimester of pregnancy. Its other drug interactions, specifically speaking on Coumadin. Celebrex may increase the anticoagulant effect of Coumadin and therefore increases the risk for bleeding. Celebrex itself does not inhibit any kind of platelet aggregation and it does not promote bleeding. However, the drug may enhance the anticoagulant effect of Coumadin. Celebrex may be combined with Coumadin, but effective Coumadin should be monitored closely, especially during the first few days of treatment, and you may actually need to lower that Coumadin dose. Other interactions. Information on the interactions of Celebrex with other medications is still limited. It may decrease the diuretic effects of Lasix as well as antihypertensive effects of ACE inhibitors. Conversely, Celebrex may increase levels of lithium, so levels of Celebrex may need to be adjusted. Levels of Celebrex may also increase or may be increased by the antifungal drug fluconazole. Again, its preparation, dosage, and administration. Hit pause and take a look, please. That brings us to, I believe, the last medication, Tylenol. Tylenol is like aspirin in many respects, but very different in others. Tylenol has analgesic and antipyretic properties, equivalent to that of aspirin. However, in contrast to aspirin and other NSAIDs, Tylenol is devoid of clinically useful anti-inflammatory and anti-rheumatic actions. In addition, Tylenol does not suppress platelet aggregation, does not cause gastric ulceration, and does not decrease renal blood flow or cause any kind of renal impairment. However, Tylenol overdose can cause severe liver injury. In the US, Tylenol is used more than any other analgesic. So how does it work? Differences between the effects of Tylenol and aspirin are thought to result from selective inhibition of cyclooxygenase, the enzyme needed to make prostaglandins and related compounds. Where aspirin can inhibit cyclooxygenase in both the CNS and the periphery, inhibition by Tylenol is limited strictly to the central nervous system. Tylenol has only minimal effects on cyclooxygenase at peripheral sites. By decreasing prostaglandin synthesis in the CNS, Tylenol is able to reduce fever and pain. The inability to inhibit prostaglandin synthesis outside of the CNS may explain the absence of anti-inflammatory effects, gastric ulceration, and adverse effects on both the kidneys as well as issues with platelets. So, its pharmacokinetics. Well, Tylenol is readily absorbed after an oral dose and undergoes a wide distribution. Most of each dose is metabolized in the liver, and its metabolites are excreted in the urine. Plasma half-life is approximately 2 hours. Tylenol can be metabolized in two major pathways. One is major and one is minor. The major pathway, Tylenol, undergoes deconjugation with glucouronic acid and other compounds to form non-toxic metabolites. The minor pathway, Tylenol is oxidized by the cytochrome P450, containing enzyme into a highly reactive toxic metabolite, which would be that N-acetyl P-benzoquinone imine. At therapeutic doses, practically all of the drug is converted to non-toxic metabolites through the major pathway. Only a small fraction is converted into the toxic metabolite through the minor pathway. Furthermore, the normal conditions, the toxic metabolite undergoes a rapid conversion to a non-toxic form. Glutathione is required for that conversion. In an event of a Tylenol overdose, a larger than normal amount is processed through the minor pathway, and therefore a larger quantity of the toxic metabolite is produced. As the liver attempts to clear that metabolite, glutathione is rapidly depleted and further detoxification stops. So as a result, the toxic metabolite accumulates, which is what causes that liver damage. And here is a picture version of what I just said, the metabolism of Tylenol. It's about to hit pause if you want to take a look at the picture. So, adverse effects. Adverse effects are extremely rare at a therapeutic dose. Tylenol does not cause gastric ulceration or renal impairment and does not inhibit platelet aggregation. Additionally, there is no evidence linking Tylenol with Rey syndrome. Individuals who are hypersensitive to aspirin only rarely experience a cross-hypersensitivity to Tylenol. Overdose, however, can cause severe liver injury. Data from the Nurses' Health Study show an association between daily use of Tylenol and development of hypertension. Additional studies that examined a possible relationship between Tylenol and hypertension in both men and women found conflicting results. Until more data is available, it would be prudent to monitor blood pressure in patients who take Tylenol daily. The mechanism by which Tylenol might raise blood pressure is, however, considered unknown. Studies have shown an association between Tylenol and the development of asthma. However, again, with hypertension, the causal relationship hasn't been truly established. In fact, specifically regarding asthma, the association may well be the other way around. That is, people may be taking Tylenol because they have respiratory symptoms, rather than having respiratory symptoms because they took a Tylenol. To prove that Tylenol actually does cause asthma, stronger data is definitely still needed at this time. Rarely, patients experience anaphylaxis, a severe hypersensitivity reaction characterized by breathing difficulty associated with the swelling of the face, mouth, and throat. If, however, those symptoms develop, patients need to seek immediate medical attention. Tylenol use also has been associated with Stevens-Johnson syndrome, acute generalized exanthematous pustulosis, and toxic epidermal necrolysis. Both Stevens-Johnson syndrome and TEN are characterized by a painful rash, blistering of the skin and mucous membranes, and detachment of the epidermis. These are considered medical emergencies because they can result in death. Recovery can take anywhere between weeks to months. Your AGEP, again, that acute generalized exanthematous pustulosis, is characterized by pustular lesions that predominantly affect the upper trunk and body folds. AGEP usually resolves within 2 weeks of onset. These reactions can occur at any time, even if the patient has been taking Tylenol prior. If a rash appears while taking Tylenol, the drug should be stopped and the patient should seek medical attention. Drug and vaccine interactions. So, we'll start off with alcohol. Regular alcohol consumption may increase the risk for liver injury when you are taking Tylenol, but only if the Tylenol dosage is considered excessive. 3 mechanisms are involved in that aspect. First, alcohol induces the synthesis of the P450 containing enzyme in the minor metabolite pathway, thereby increasing the production of Tylenol's toxic metabolite. Second, stores of glutathione are depleted in chronic alcoholics. So as a result, the liver is already unable to convert the toxic metabolite to its non-toxic form. Third, chronic alcohol abusers often have pre-existing liver damage, which renders them less able to tolerate injury from Tylenol use. So, alcohol in combination with Tylenol can increase the risk for liver and kidney damage. Although information regarding liver disease and Tylenol has existed for some time, newer data still reveals that even a low-dose combination of alcohol and Tylenol can lead to renal dysfunction. Authorities recommend that if you do drink alcohol on a regular basis, you should consume no more than 2 grams of Tylenol a day. Although therapeutic doses of Tylenol may be safe for alcohol drinkers, a higher dose certainly is not. Accordingly, to alert the public to the potential risk of combining alcohol with Tylenol, the FDA requires Tylenol labels bear the following statement. Alcohol warning. If you consume 3 or more alcoholic drinks every day, ask your doctor whether you should take Tylenol or other pain relievers and fever reducers. When used in combination with Coumadin, there is evidence that Tylenol may increase the risk for bleeding in patients who are taking Coumadin. This is surprising because unlike other NSAIDs, Tylenol does not suppress platelet aggregation, and so you shouldn't promote bleeding. Yes, Tylenol may inhibit Coumadin's metabolism, which would cause Coumadin levels to rise, although this interaction has not been proven. Caution is for now still advised. Accordingly, for patients taking more than 1 gram of Tylenol daily for several days, responses to Coumadin should be monitored closely. occasional use of Tylenol should not be a concern. When receiving vaccines, Tylenol and other analgesic antipyretics can blunt the immune response to childhood vaccines. So accordingly, routine use of these drugs to prevent vaccination-associated pain or fever is discouraged. So it's therapeutic use. Tylenol is indicated for the relief of pain and fever. Because Tylenol is again not associated with Rey syndrome, it is the preferred drug choice compared to NSAIDs in children who are suspected of having chickenpox or NSAIDs. Because it does not cause any kind of GI injury, Tylenol again is preferred over NSAIDs in patients who have PUD. In addition, Tylenol may be a safe alternative to aspirin for patients who have experienced aspirin hypersensitivity reactions. Because it has a weak anti-inflammatory action, Tylenol is not useful in treating arthritis or rheumatic fever. So that takes us now to our acute toxicity, especially its liver damage. Again, overdose of Tylenol can cause severe liver injury and potential death. The cause is accumulation of toxic metabolites, which was already discussed. In the US, Tylenol overdose, intentional or unintentional, is the leading cause of liver failure, which accounts for up to 50% of all cases. Risk for liver injury is increased by fasting, chronic alcohol use, and taking more than 4 grams of Tylenol daily. So what are the signs and symptoms then of a Tylenol overdose? Well, it's hepatic necrosis. Severe poisoning can progress to hepatic failure, coma, and death. Your early symptoms is nausea, vomiting, diarrhea, sweating, abdominal discomfort, belie the severity of intoxication. It's not until about 48 to 72 hours after the drug ingestion that overt indications of hepatic injury start to appear. So, how can we help prevent and treat? Well, the liver damage can be minimized by giving acetylcysteine or Mucomyst, which is the specific antidote to Tylenol. Mucomyst reduces injury by substituting for depleted glutathione in the reaction that converts the toxic metabolite into its non-toxic form. When given within 8 to 10 hours of a Tylenol overdose, Mucomyst is 100% effective at preventing severe liver injury. And even when administered as much as 24 hours after the poisoning, it can still provide a significant amount of protection. Mucomyst may be administered either orally or intravenously. Again, for dosages on Mucomyst, take a look here, hit pause. Keep in mind though, that for most patients, treatment can be stopped after 20 hours of receiving Mucomyst. Oral Mucomyst has an extreme unpleasant odor and may induce vomiting. If the patient's unable to tolerate dosing, Mucomyst can be administered again via the IV or NG tube route. So, it's important that we are minimizing our risk. Risk for liver failure is very low with normal therapeutic doses, except for people again who drink alcohol, are considered undernourished, or have a history of liver disease. Patient education also can help reduce this injury. So, the following information should be given. Inform patients about the risk for liver toxicity. Advise patients not to consume more than 4 grams a day. Advise them, patients who are undernourished, to consume no more than 3 grams a day. Patients should be taught not to drink alcohol while taking Tylenol. And again, you want to promote actual alcohol abstinence. Advise patients also who have liver disease to ask their prescriber if Tylenol is safe for them specifically. Again, to help reduce an overdosage, there is the McNeil Consumer Healthcare, maker of the Tylenol brand of Tylenol, changing the dosing recommendation on Tylenol tablets. So there are other options out there. There's also other manufacturers that are expected to make similar changes in terms of its regular strength versus extra strength. So, its preparation, dosage, and administration. Numerous Tylenol containing products are on the market. So there is a wide assortment of fixed dose combinations. Again, it's available as a rectal suppository, an oral solution, an IV solution, whether it's a chewable tablet, a standard tablet, an extended release tablet, a capsule, a liquid gel, and. So lots of options for different patient populations. Keep in mind that all of these products here are because they can create a significant risk for potential overdose, especially if they're taking more than one type. So it's important to educate the patient that don't mix and match to get to 4 grams. Stick to one type. So speaking now strictly on oral dosages. Again, I'm not going to speak on the dosages themselves, but here is that spot where you can hit pause, because you'll see both the oral and the rectal dosage and how often you can give it. And then I think here is that last little statement. The American Heart Association, or AHA, statement on cyclooxygenase inhibitors for those who have chronic pain. Because most COX inhibitors, especially that COX-2 inhibitor, increases the risk for an MI or stroke, the American Heart Association recommends a stepped care approach to their use. As discussed in the article, the use of NSAIDs, an update for clinicians, a scientific statement from the AHA. Recommendation in this article applies specifically to managing musculoskeletal pain in a patient with or at high risk for cardiovascular disease. So the recommendation may also apply to patients who lack documented cardiovascular risk. The approach has 4 basic steps. The first, begin with non-drug measures. Again, options include PT, OT, exercise, weight loss, orthotics, trying heat packs or cold packs. Then we advance to step 2. If the non-drug measures don't work, initiate a drug therapy using Tylenol or aspirin, which do not increase cardiovascular risk. Again, if these drugs can't control the pain, an opioid or tramadol can be trialed, but only for short term. Step 3, well, if step 2 drugs are ineffective or intolerable, try other non-selective NSAIDs. So that would be our naproxen, ibuprofen, and non-acetylated salicylates. And then our last step, step 4, as a last resort. Try the selective COX-2 inhibitor, Celebrex. Of all the NSAIDs, COX-2 inhibitors pose the greatest risk for cardiovascular harm. And therefore, Celebrex is the last choice drug for chronic pain. When these drugs are employed, patients should use the lowest effective dosage for short-term required. During steps 2, 3, and 4, if the patient is considered at high risk for a thrombotic event, low-dose aspirin plus a PPI or an H2RA needs to be added to their regimen. And that concludes our chapter here for today. I know I said please hit pause a lot today, but that's because there's lots of medications being thrown out with lots of different dosages. I thank you as always for listening, and I hope you have a wonderful rest of your day. Thank you, and goodbye.